it's another journal club. Oh, Declan, you don't look so good.
I'm a bit of man flu, actually.
It's a serious problem.
Thank you for the sympathy. You're not normally so sympathetic to me.
Oh, I wonder, is it because we're not doing prostate cancer today?
All right, well.
Oh, no. He
speechless.
does sound bad. He does sound bad.
Well, yeah, welcome to this journal club, but I might bail out shortly because it's a bit disgusting listening to someone in your ears that got man flu.
Lots of sympathy for you, Declan.
Yes, thank you so much. But thank you to our partners, as ever, MSD, who support our journal club. We're 6 months into it now, I think.
Yeah, it's amazing. We've 6 episodes. 7. This is our 7th one.
6 or 7, I think.
Yeah.
That's great.
It's been a lot of fun.
It has, and thank you for all the feedback. People who've been suggesting papers to us and sending really nice comments about our journal club editors, Carlos Delgado, who's here in the studio with us, and Elena Berg, who's joining us from Munich. Hello, Elena.
Hello, I'm very good. How are you?
Great, good to see you. Now, more news about Elena in a minute.
Yeah, well, there's lots to celebrate. I wonder if we'll actually get to these papers because Carlos has just come back after getting married in Mexico. Huge congratulations to Carlos and new wife, Emilia. Well done.
Thank you, Renu. Thank you, Declan.
It looked incredible.
Oh, yes, presidential
wedding.
Wedding that Declan was saying.
It looked like the royal wedding of the year in Mexico.
That's not true.
I think you booked out the whole city, didn't you?
No, I didn't.
Well, it looked incredible. He's been treating us to lots of photos and videos. There's lots out on Instagram. So we've kind of been on this great journey with you. And it's great to have you back, though. And Emilia will be joining you shortly here as well.
Yes, you will coming in April.
Fantastic.
Awesome. We look forward to that.
And more good news.
And more good news before we get into the papers. Yes. So Elena,
this will be the last time Elena joins us on Zoom because she will be here in person in exactly a week from now. Is that right, Elena?
Yeah, that's right. I'm very much looking forward to that until leaving behind the grey German weather and join sunny Melbourne.
Bit of a grey day in Melbourne today, but the weather is looking good and will be for your arrival. And Elena is going to be joining us as our new fellow at Peter Mac. And so we'll have, for our next episode of the GU Cast Journal Club, we'll have all 4 of us in the studio together.
In person. Amazing.
Yeah, so much nicer in person.
So looking forward to it. So we got 2 cracking papers. The links, as ever, are going to be in the show notes for these papers. And you know we got a lot of WhatsApps going when we're trying to pick out these papers, haven't we, Renu?
Yeah, I mean, we have selected some fantastic landmark key papers that have changed practice, and great acronyms for the 2 papers today. We have the POUT trial of perioperative chemotherapy in upper tract urothelial cancer, and the SEMS trial, which is looking at the role of surgery in early metastatic seminoma. So 2 fantastic trials. The POUT trial was published in Lancet Oncology in 2020 and the SEMS trial in JCO in 2023. So 2 fantastic trials, but no prostate cancer today, Declan.
Yeah, there you go. And often, I mean, there are a lot of papers in prostate cancer. So when we're tossing around what should we discuss, we're not doing 2 prostate cancers. We had a rule of like maximum 1, but now we got 0 prostate cancer.
We knew this day would come.
That's good. That is good.
All right, shall we get onto it?
Yeah, so I think, Elena, you're going to cover the POUT trial. So the format, as ever, regular listeners and viewers will know, is Elena will give us a high-level quick summary of this paper and then talk a bit about strengths and limitations. We'll have a quick chat about it and then we'll do the SEMS paper and we'll try and wrap it all up in 30 minutes like ideal journal club.
Absolutely.
As you're on the way to work or, pottering around at home, getting some exercise, getting dinner ready, whatever it is. Hopefully this journal club will help you learn about the POUT trial and the SEMS trial. So yeah, Elena, over to you.
Yeah, so we know that upper tract urothelial carcinoma is comparably rare and accounts for about 5 to 10% of all urothelial carcinomas, and it has a poorer prognosis compared to bladder cancer. Prior to the POUT trial, no consensus existed on the benefit of adjuvant chemotherapy following radical nephro-ureterectomy for upper tract urothelial cancer, and treatment recommendations were largely extrapolated from bladder cancer data. The POUT trial was a phase 3 trial designed to evaluate whether platinum-based adjuvant chemotherapy improves outcomes in patients with locally advanced upper tract urothelial cancer after curative intent surgery. A total of 261 patients were randomized between 2012 and 2017 in the UK who had received a radical nephro-ureterectomy and was staged as either muscle-invasive, PT2 to PT4, or lymph node positive, but metastasis-free and fit to receive chemotherapy. They were assigned to either 4 cycles of adjuvant chemotherapy with cisplatin or carboplatin in combination with gemcitabine or surveillance. Impaired renal function with a GFR of 30 to 50 was the only reason that patients would receive carboplatin instead of cisplatin, which was about 36% of patients. The primary endpoint was the disease-free survival. Secondary endpoints were overall survival, metastasis-free survival, safety, and quality of life. And patients were followed up by CT and cystoscopy up to 60 months. When we look at the results, the 3-year disease-free survival and in an updated analysis, the 5-year disease-free survival was significantly longer for patients who received adjuvant chemotherapy, with 71% versus 46% for patients under surveillance. A 55% reduction in relative risk of disease recurrence or death was seen for the chemotherapy group. And participants allocated to chemotherapy had a lower risk of metastasis with event-free rates of 71% versus 53%. Treatment effects were interestingly consistent across chemotherapy regimens, whether they received carboplatin or cisplatin. Toxicity was, of course, higher in the chemotherapy group with 44% grade 3 or higher. There was, again, no difference if they received cisplatin or carboplatin, interestingly, compared to 4% of those managed by surveillance. Grade 3 or higher adverse events in the chemotherapy group were especially neutropenia, febrile neutropenia, decreased platelet count, and nausea and vomiting, as we know it from platinum-based chemotherapies. Quality of life was also assessed and showed a lower overall global health status during and immediately after chemotherapy, but that difference resolved within 6 months. So in conclusion, it was shown that gemcitabine platinum chemotherapy given within 90 days after radical nephro-ureterectomy significantly improved disease-free survival and metastasis-free survival in patients with locally advanced upper tract urothelial cancer, and established that as a new standard of care. When we look at strength and limitations of the trial, we see that it's a high-level design exclusively in patients with upper tract urothelial cancer, addressing an evidence gap rather than just relying on the extrapolation from bladder cancer data. It was a clinically relevant population. It was patients with PT2 to PT4 node positive disease, a high-risk group where adjuvant decisions matter a lot. It included patient-centered outcomes and the quality of life assessment. A thing to keep in mind is that the primary endpoint was disease-free survival, which is clinically, of course, useful, but it's still a surrogate. Overall survival was a secondary endpoint and initially immature, later showing a non-significant trend toward improvement. The completion rate of 75% for all 4 cycles underscores the reality that post-nephro-ureterectomy renal function may decline and may impact the ability to deliver adjuvant chemotherapy. Another point is that extended lymph node dissection was not required and only abnormal nodes were resected, potentially missing nodal metastasis in patients that were later characterized as PN0, which was 91%. The toxicity burden was, of course, significant. Around 44% of patients starting chemotherapy had grade 3 or higher acute treatment emergent adverse events. However, the trial significantly advanced the integration of systemic therapy in upper tract urothelial cancer, establishing adjuvant treatment and laying the foundation also for perioperative approaches.
Sorry, Elena. I had muted us off.
Oh,
Yeah, your whole lovely comment.
jeez.
Sorry, I was sniffling. I muted us off. Thank you. Sorry about that. So we'll have to go from she finished it up. Sorry,
Yeah.
you
No,
did a
no,
lovely
that's
summary
all right.
and a shout out to Alison Berkel.
Yeah.
And
We'll wing it.
will you wing it again?
Yeah.
Okay, so we'll pretend she's just finished.
Yeah.
Give us a couple of seconds and we'll go. Excellent.
Okay.
Sorry.
No worries. Fantastic, great summary, Elena, and really quite a landmark paper, isn't it? And a huge shout out to our good friend Alison Bertel, who's first author of this paper that was published in The Lancet in 2020. Upper tract urothelial cancer is a challenge for us. It's often diagnosed a little bit late, and diagnosis can be problematic because unlike bladder cancers, where we get those nice biopsies and sampling of the muscle, that's often not possible with upper tract urothelial cancer. So a lot of these patients do tend to do worse. And so these options are really great news for patients. And it's a trial that closed early because we saw this incredible benefit in favor of adjuvant chemotherapy. Elena, I guess now with data like this, I guess we have to think about patient selection. Does everyone who fit into this POUT trial criteria benefit, or is there any way that we can predict who might benefit more and select patients a little bit more carefully to avoid the effects of chemotherapy in those who may not need it?
I think the criteria were quite good for patient selection. It was a high-risk population with those PT2 to PT4 or node-positive disease. So we know that exactly this group is the one who will profit the most from it.
Yeah.
It's always the question with adjuvant as well that we've often discussed on the podcast, isn't it? When patients don't have disease and you're treating to prevent future disease, and the bar for toxicity you have to consider a little bit carefully, don't you? And on that point, I suppose, Elena, we're now in the era where we have all these immunotherapies, of course, for urothelial cancer. This is good old-fashioned chemo, Gem-Cis or carboplatin. This trial is still very, very important, but do you think in the coming years it'll be rendered historic because we will be using immunotherapies instead in this setting?
With the perioperative therapies, we've seen that immunotherapy plays a huge role as well. And when we look at the EAU guidelines, for example, we do have this weak recommendation also for nivolumab or pembrolizumab with the trials that looked at that also in bladder cancer with a low but still relevant percentage of patients who had upper tract urothelial cancer as well. So that is going to play a large role probably, and also in the perioperative setting with neoadjuvant and adjuvant treatments.
Yeah, I think that's a really good point, Elena. I think moving forward, we will be trying to move these systemic therapies more into the neoadjuvant and in the perioperative setting. Right now for upper tract, I guess we have to extrapolate from the data we have for bladder cancer, but it's been standard of care now for many years with now the addition of immunotherapies in the perioperative setting for bladder cancer. So I imagine this will go down a similar route.
Yeah, and of course, we've just posted that podcast with Christoph Volstecki about EV303, which is like a bit of a revolutionary trial with this 60% complete response rates in bladder. So the whole field of urothelial cancer feels like it could totally change, couldn't it?
Absolutely.
So
great presentation.
POUT
so trial.
If you're listening
2020.
to that, if you're a trainee out there, you're on your way into work, and there's a post, nephro-ureterectomy patient on the MDT. And you need to be the one to stick your hand up and say, yes, what about adjuvant chemo here? The POUT trial showed a 55% reduction, hazard ratio 0.45 in favor of good old-fashioned chemo.
That's right.
And you just sound super smart.
Absolutely.
Speaking of super smart.
Oh, yes, the SEMS trial. I like this one. Over to you, Carlos, for the SEMS trial. This is surgery in early metastatic seminoma.
Thanks, Declan. Thanks, Renu. This is a great trial. This is a prospective phase 2 study evaluating primary RPLND in early metastatic seminoma. This paper is very important because it challenges a long-standing dogma that all of the stage 2 seminoma patients need to receive chemotherapy in order to be cured. And yes, cisplatin is great, but there's long-term toxicities in such a young population that has their entire life ahead of them. Cure rates for stage 2 seminoma are excellent, often above 90%, but the price we pay is not trivial. Long-term data has shown increased risk of cardiovascular disease, metabolic syndrome, lower fertility, secondary malignancies, and overall excess mortality decades later related to chemotherapy and radiotherapy side effects. In non-seminoma germ cell tumors, primary RPLND is already an accepted option in low-volume retroperitoneal disease. However, in seminoma, it has traditionally been treated differently, largely because its radiosensitivity and chemosensitivity. The SEMS investigators ask a simple but important question. Can we use surgery alone in carefully selected patients with low-volume metastatic seminoma and spare them from chemotherapy or radiation? SEMS was a prospective multi-institutional single-arm phase 2 trial conducted across 12 centers in the US and Canada. Eligible patients had pure seminoma, prior ureterectomy, and isolated retroperitoneal lymphadenopathy between 1 and 3 centimeters, no more than two lymph nodes within an ipsilateral RPLND template, and no distant disease. And very importantly, all with negative serum tumor markers. All patients underwent an open RPLND performed by experienced credentialized surgeons. The primary endpoint was two-year recurrence-free survival with secondary endpoints including complications, recurrence patterns, need for adjuvant therapy, and treatment-free survival. 55 patients were enrolled with a median largest clinical node size of 1.6 centimeters. On final pathology, 16% were PN0, and notably, pathological upstaging was common, with more than half of these patients having PN2 disease. At a median follow-up of 33 months, the 2-year recurrence-free survival was 81%, with an overall recurrence rate of 22%. Importantly, all recurrences were salvaged successfully, mostly with chemotherapy, and overall survival at 2 years was 100%. In practical terms, the majority of patients avoided chemotherapy. From a surgical standpoint, outcomes were reassuring. Short-term complications occurred in 7% of the patients, and long-term complications occurred as well in 7% of the patients. An ejaculation was seen in 5% of the patients, and this was exclusively seen in patients that received a non-nerve-sparing surgery. There were no perioperative deaths, the blood loss was minimal, the median hospital stay was only 3 days, and this highlighting that in expert centers, RPLND can be performed safely. Key strengths of the SEMS trial include prospective multi-institutional design, extreme patient selection, central focus on survivorship and treatment de-escalation, and it demonstrated that even in patients with recurrence, these patients can be salvaged with a highly effective salvage therapy. This study adds high-quality evidence to a space previously dominated by retrospective series. There's, however, other studies that have also looked into this, the COTRIMS trial, also the German trial by Heidenreich. There are no important limitations to keep in mind. There are more important limitations to keep in mind. This was a single-arm phase 2 trial without a direct comparator. Follow-up remains relatively short for seminoma, in which we see late recurrences. Surgeries were performed by highly volume RPLND surgeons, so these results may not be achieved in outside of high volume centers. Clinically, SEMS trial tells us that primary RPLND is a reasonable option for very select group of patients with low volume stage 2 seminoma, particularly those motivated to avoid chemotherapy or radiation. It moves the focus beyond cure alone toward achieving cure with the lowest possible long-term toxicity. Importantly, this approach relies on careful selection, shared decision-making, and access to expert surgical teams. In summary, the SEMS trial shows that surgery alone can cure a majority of patients with early metastatic seminoma with acceptable recurrence rates and excellent options for salvage therapies. While more data is needed to replace chemotherapy as the standard option, it expands the treatment options for selected patients, and that's a meaningful step forward in survivorship-focused care.
Awesome.
Very nice, Carlos. Wonderfully summarized there. And again, a shout out to a couple of our friends, Declan. Sia Dineshmand is first author in this study. And I see Christian Kolsmanberger on the list of authors as well. He's been
here in the studio with Ben Tran.
Yeah, that's right. So some great names behind this paper that was published at JCO in 2023. So, Carlos, really important trial because, I mean, chemotherapy and testis cancer, this has been the success story, right, in urology. High cure rates for metastatic disease. But we know that this disease affects young patients who are going to live long enough to experience many of the toxicities, especially the late toxicities. So that's why we're bringing concepts like surgery further and further kind of forward in the disease spectrum. These surgeries are not easy, right? And you did mention you need experienced surgeons. Those who are high volume RPL&D surgeons will often say, in fact, though, that upfront surgery is like a dream compared to the salvage surgeries. So it can benefit both camps, right?
Yes, of course. We always hear about this post seminoma RPL&Ds and how awful it is to get a plane on them. So this is a great opportunity to give these patients an opportunity to cure them, and with a relatively safely option.
Absolutely. Declan, I still remember Nathan Larenchuk, who is a high-volume RPL&D surgeon with us here in Melbourne. When he talks about salvage RPL&D, he always says, it's one of those days you have to bring a couple of extra pairs of underwear for the locker.
Sounds like Nathan. Mind, he does tend to get referred the most challenging ones where a kidney's coming as well, or there's going to be a replacement of some, aorta.
We did a podcast with European Urology Oncology about the COTRIMS trial with Axel Heidenreich. That was published in European Urology Oncology in 2024. And they also looked at, stage 2 metastatic seminoma and the role of a nerve-sparing RPL&D and showed that it was really not inferior to systemic chemotherapy. So, I mean, in the right hands, in experienced surgeons, this can offer a very good alternative to well-informed patients who want to avoid the toxicities of chemotherapy.
And we've certainly seen a big change in our centre, at Peter MacCallum Cancer Centre, where we have a very, very big metastatic testis cancer quaternary referral pattern. And certainly 10 years ago, we were never doing surgery up front like this. But now it's being driven by our lead GU medical oncologist, by Ben Tran and Jeremy Liu, and they're turning us to say, we want to be offering surgery to these patients. And it's kind of coincided with the robot now being actually very good for these cases as well. So, Carlos, can I ask you a question about that? Because this is all open surgery, I think, isn't it?
Yes, this is all open surgery.
Yeah.
But
with very good results. But, in the modern era, in these high-volume centres with high-volume surgeons, increasingly, especially for the primary, not the salvage setting, these patients will be offered a minimally invasive approach as well.
I think in this very specific case, the robot could make patients access to surgery safely in a more wildly or expanded way. There's another trial from the Swedish and Norwegian group who also look into this, and they included most of the patients were operated with a robotic RPL&D, and they achieved a similar results as the COTRIMS trial.
Yeah.
Awesome. Elena, can we ask you in Germany, because as Renu mentioned, the Heidenreich group, of course, have also published prospective data on this, but what's the practice in Germany? Is it surgery up front for stage 2 seminoma or chemotherapy?
It's probably still more chemotherapy. We kind of stick to the EAU guidelines, which state radiotherapy and chemotherapy, that they show similar effectiveness. But I think in huge testicular cancer centers, as it is with Axel Heidenreich, they do perform upfront surgery as well.
Yeah, I mean, I guess the things to remember are centralization of care is really important. These sorts of surgeries should be done in high volume centers with very experienced surgeons. Patients need to be followed up very closely. Surveillance afterwards is really important. So that collaboration with your medical oncologists and urologists continue to be very important in this particular setting.
2 great papers.
Yeah.
Very, very convincingly delivered by Carlos and Elena. Again, that was hopefully the viewers and audience really enjoyed that.
Yeah. Well, you need some Lemsip or maybe some whiskey.
You reckon?
Yeah, some Irish whiskey.
I might go round to your house. You've got a big collection of whiskey around the corner.
That will cure it, Declan.
And of course, we're posting this just before USANS, which kicks off later this week. You're the convener. It's a busy week coming.
Busy week.
And then EAU next month. So for any fans of Journal Club, Carlos and Elena will both be coming to the EAU with us. They'll be there and helping out with our GUcast live event on the Sunday evening.
Don't miss that one.
Don't miss that one. And we'll have
you can get Carlos' autograph.
Oh, yeah, exactly. That's right. Yeah, congratulate him on his wedding.
And Elena's.
Yes.
We can get a beer. That for sure.
Super. Well, look, thank you very much. Thank you very much, Carlos, for joining us. Welcome back.
Thank you.
Safe travels, Elena. We'll see you in the flesh very soon.
Yeah, thank you. See you soon.
And that's all we have time for on this episode of GUcast Journal Club. Thanks again to MSD, our Journal Club partners, for supporting this very worthwhile initiative. We'll be back soon.